Endometriosis, diagnosis and management. Endometriosis is one of the most common gynecological disease needing treatment. It is defined as the growth of endometrial-like tissue, the womb lining outside the uterus. Endometriosis is mainly a disease of reproductive years, and although its exact cause is unknown, it is hormone-mediated and associated with menstruation. Delayed diagnosis, 7 to 8 years on average, is a significant problem for women with endometriosis. Delays of 4 to 10 years can occur between first reporting symptoms and confirming the diagnosis. It leads to increased personal suffering, prolonged ill health, and disease state that is more difficult to treat. Endometriosis can be a chronic condition affecting women throughout their reproductive lives and sometimes beyond. Women's priorities and preferences may change over time, and management strategies should change to reflect this. Women with endometriosis typically present to community services, including GPs, practice nurses, school nurses, and sexual health services with pain, and may then be referred to gynecological services for diagnosis and management. Some women may present to fertility services. Complex surgical treatment is carried out in specialist endometriosis services or endometriosis centers, which incorporate a multidisciplinary team. Organization of care. Set up a managed clinical network for women with suspected or confirmed endometriosis, consisting of community services including GPs, practice nurses, school nurses, and sexual health services, gynecology services, and specialist endometriosis services. Community gynecology and specialist endometriosis services should provide coordinated care for women with suspected or confirmed endometriosis, have process in place for prompt diagnosis and treatment of endometriosis, because delays can affect quality of life and result in disease progression. Gynecology services for women with suspected or confirmed endometriosis. Gynecology services for women with suspected or confirmed endometriosis should have access to a gynecologist with expertise in diagnosing and managing endometriosis, including training and skills in laparoscopic surgery, a gynecology specialist nurse with expertise in endometriosis, a multidisciplinary pain management service, a healthcare professional with an interest in gynecological imaging, fertility services. Specialist endometriosis services. Specialist endometriosis services should have access to gynecologists with expertise in diagnosing and managing endometriosis, including advanced laparoscopic surgical skills, a colorectal surgeon with an interest in endometriosis, a urologist with an interest in endometriosis, an endometriosis specialist nurse, a multidisciplinary pain management service with expertise in pelvic pain, a healthcare professional with specialist expertise in gynecological imaging of endometriosis, advanced diagnostic facilities, for example, radiology and histopathology, fertility services. Endometriosis information and support. Endometriosis can be a long-term condition and have a significant sexual, physical, psychological, and social impact. Women may have complex needs and require long-term support. Assess the individual information and support needs of women with suspected or confirmed endometriosis, taking into account their circumstances, symptoms, priorities, desire for fertility, aspects of daily living, work and study, cultural background, and their physical, psychosexual, and emotional needs. Provide information and support for women with suspected or confirmed endometriosis, which should include what endometriosis is, endometriosis symptoms and signs, how endometriosis is diagnosed, treatment options, local support groups, online forums, and national charities, and how to access them. If women agree, involve their partner and/or other family members or people important to them and include them in discussions. Endometriosis symptoms and signs. Endometriosis is typically associated with symptoms such as pelvic pain, painful periods and subfertility, a lower quality of life, pain, which can be frequent, chronic and/or severe, as well as tiredness, more sick days, and significant physical, sexual, psychological, and social impact, subfertility, and this can also have a significant effect on quality of life. Women may also have endometriosis without symptoms. Suspect endometriosis in women, including young women aged 17 and under, presenting with one or more of the following symptoms or signs. Chronic pelvic pain, defined as pelvic pain lasting for 6 months or longer. Period-related pain, dysmenorrhea affecting daily activities and quality of life. Deep pain during or after sexual intercourse. Period-related or cyclical gastrointestinal symptoms, in particular painful bowel movements. Period-related or cyclical urinary symptoms, in particular blood in the urine or pain passing urine. Infertility in association with one or more of the above. Inform women with suspected or confirmed endometriosis that keeping a pain and symptom diary can aid discussions. History is more informative in diagnosing it. Referral for women with suspected or confirmed endometriosis. Consider referring women to a gynecological service for an ultrasound or gynecology opinion if they have severe, persistent, or recurrent symptoms of endometriosis. They have pelvic signs of endometriosis, or initial management is not effective, not tolerated, or is contraindicated. Refer women to a specialist endometriosis service, endometriosis center, if they have suspected or confirmed deep endometriosis involving the bowel, bladder, or ureter. Consider referring young women aged 17 under with suspected or confirmed endometriosis to pediatric and adolescent gynecology service. Gynecology service or specialist endometriosis service depending on the local service provision. Diagnosing endometriosis. Diagnosis can only be made definitively by laparoscopic visualization of the pelvis, but other less invasive methods may be useful in assisting diagnosis, including ultrasound. Management options for endometriosis include pharmacological, non-pharmacological, and surgical treatments. Endometriosis is an estrogen-dependent condition. Most drug treatments for endometriosis work by suppressing ovarian function and are contraceptive. Surgical treatment aims to remove or destroy endometriotic lesions. The choice of treatment depends on the woman's preferences and priorities in terms of pain management and/or fertility. Do not exclude the possibility of endometriosis if the abdominal or pelvic examination, ultrasound or MRI are normal. If clinical suspicion remains or symptoms persist, consider referral for further assessment and investigation. Ultrasound. Consider transvaginal ultrasound to investigate suspected endometriosis even if the pelvic and/or abdominal examination is normal. To identify endometriums and deep endometriosis involving the bowel, bladder, or ureter. If a transvaginal scan is not appropriate, consider a transabdominal ultrasound scan of the pelvis. Serum CA125. Do not use serum CA125 to diagnose endometriosis. If coincidentally reported serum CA125 level is available, be aware that a raised serum, that is 35 international unit per milliliter or more, may be consistent with having endometriosis. Endometriosis may be present despite a normal serum CA125 less than 35 international units per milliliter. MRI. Do not use pelvic MRI as the primary investigation to diagnose endometriosis in women with symptoms or signs suggestive of endometriosis. Consider pelvic MRI to assess the extent of deep endometriosis involving the bowel, bladder, or ureter. Ensure that pelvic MRI scans are interpreted by a healthcare professional with specialist expertise in gynecological imaging. Diagnostic laparoscopy offers surgical management if fertility is a priority. Consider laparoscopy to diagnose endometriosis in women with suspected endometriosis, even if the ultrasound was normal. For women with suspected deep endometriosis involving the bowel, bladder, or ureter, consider a pelvic ultrasound or MRI before an operative laparoscopy. During a diagnostic laparoscopy, a gynecologist with training and skill in laparoscopic surgery for endometriosis should perform a systematic inspection of the pelvis. During a diagnostic laparoscopy, consider taking a biopsy of suspected endometriosis. To confirm the diagnosis of endometriosis, be aware that a negative histological result does not exclude endometriosis. To exclude malignancy, if an endometrioma is treated but not excised. If a full systematic laparoscopy is performed and is normal, explain to the woman that she does not have endometriosis and offer alternative management. Staging systems offer endometriosis treatment according to woman's symptoms, preferences, and priorities rather than the stage of endometriosis. When endometriosis is diagnosed, the gynecologist should document a detailed description of the appearance and site of endometriosis. Monitoring for women with confirmed endometriosis. Consider outpatient follow-up with or without examination and pelvic imaging for women with confirmed endometriosis, particularly women who choose not to have surgery if they have deep endometriosis involving the bowel, bladder, or ureter, or one or more endometrioma that is larger than 3 cm. Pharmacological pain management. Analgesics. For women with endometriosis-related pain, discuss the benefits and risks of analgesics, taking into account any comorbidities and the woman's preferences. Consider a short trial, for example 3 months of paracetamol or a non-steroidal anti-inflammatory drug, alone or in combination for first-line management of endometriosis-related pain. If a trial of paracetamol or NSAID alone or in combination does not provide adequate pain relief, consider other forms of pain management and referral for further assessment. Neuromodulators and neuropathic pain treatments. Seek advice on neuromodulators or treat neuropathic pain. Hormonal treatments. Explain to women with suspected or confirmed endometriosis that hormonal treatment for endometriosis can reduce pain and has no permanent negative effect on subsequent fertility. Offer hormonal treatment, for example, the combined oral contraceptive pill or a progestogen, to women with suspected, confirmed, or recurrent endometriosis. If initial hormonal treatment for endometriosis is not effective, not tolerated, or is contraindicated, refer the women to gynecological service, specialist endometriosis service, or pediatric and adolescent gynecology service for investigation and treatment options. Non-pharmacological management. Advise women that available evidence does not support the use of traditional Chinese medicine or other Chinese herbal medicine or supplements for treating endometriosis. Surgical management. Ask women with suspected or confirmed endometriosis about their symptoms, preferences, and priorities with respect to pain and fertility to guide surgical decision-making. Discuss surgical management options with women with suspected or confirmed endometriosis. Discussions may include what a laparoscopy involves, that laparoscopy may include surgical treatment with prior patient consent, how laparoscopic surgery could affect endometriosis symptoms, the possible benefits and risks of laparoscopic surgery. The possible need for further surgery, for example, for recurrent endometriosis or if complications arise. The possible need for further planned surgery for deep endometriosis involving the bowel, bladder, or ureter. Perform surgery for endometriosis laparoscopically unless there are contraindications. During a laparoscopy to diagnose endometriosis, consider laparoscopic treatment of the following if present. Peritoneal endometriosis not involving the bowel, bladder, or ureter, uncomplicated ovarian endometriomas. As an adjunct to surgery for deep endometriosis involving the bowel, bladder, or ureter, consider 3 months of gonadotropin-releasing hormone agonists before surgery. Consider excision rather than ablation to treat endometriomas, taking into account the woman's desire for fertility and her ovarian reserve. Consider ovarian reserve testing, FSH, antral follicular count, and AMH, anti-Mullerian hormone level. Combination treatments. After laparoscopic excision or ablation of endometriosis, consider hormonal treatment with, for example, the combined oral contraceptive pill, or prolong the benefits of surgery and manage symptoms. Hysterectomy in combination with surgical management. If hysterectomy is indicated, for example, the woman has adenomyosis or heavy menstrual bleeding that has not responded to other treatments, excise all visible endometriotic lesions at the time of hysterectomy. Perform hysterectomy with or without oophorectomy laparoscopically when combined with surgical treatment of endometriosis unless there are contraindications. For women thinking about having a hysterectomy, discuss what a hysterectomy involves and when it may be needed, the possible benefits and risks of hysterectomy, the possible benefits and risks of having oophorectomy at the same time, how a hysterectomy with or without oophorectomy could affect endometriosis symptoms, that hysterectomy should be combined with excision of all visible endometriotic lesions, endometriosis recurrence, and the possible need for further surgery, the possible benefits and risks of hormone replacement therapy after hysterectomy with oophorectomy, and provide information on surgical menopause. Surgical management if fertility is a priority. The management of endometriosis-related subfertility should have multidisciplinary team involvement with input from a fertility specialist. This should include the recommended diagnostic fertility test or preoperative test, as well as other recommended fertility treatments such as assisted reproduction. Offer excision or ablation of endometriosis plus adhesiolysis for endometriosis not involving the bowel, bladder, or ureter, because this improves the chance of spontaneous pregnancy. Offer laparoscopic ovarian cystectomy. Ovarian cystectomy is a surgical excision of an ovarian endometriotic cyst. An ovarian endometriotic metrioma is a cystic mass arising from ectopic endometrial tissue with the ovary. With excision of the cyst wall to women with endometriomas, because This improves the chance of spontaneous pregnancy and reduces recurrence. Take into account the woman's ovarian reserve. Discuss the benefits and risks of laparoscopic surgery as a treatment option for women who have deep endometriosis involving the bowel, bladder, or ureter, and who are trying to conceive, working with a fertility specialist. Topics to discuss may include whether laparoscopic surgery may alter the chance of future pregnancy, the possible impact on ovarian reserve, the possible impact on fertility if complications arise, alternatives to surgery, other fertility factors. Do not offer hormonal treatment to women with endometriosis who are trying to conceive because it does not improve spontaneous pregnancy rates. Terms used in this guideline: chronic pelvic pain, defined as pelvic pain lasting for 6 months or longer. Pediatric and adolescent gynecology service. These services are hospital-based, multidisciplinary specialist services for girls and young women, usually under 18. Ovarian cystectomy is a surgical excision of an ovarian endometriotic cyst. An ovarian endometrioma is a cystic mass arising from ectopic endometrial tissue within the ovary. Managed clinical networks. Linked groups of healthcare professionals from primary, secondary, and tertiary care providing a coordinated patient pathway. Responsibility for setting up these networks will depend on existing service provisions and location. Pain management programs. Are pain management programs a clinically and cost-effective intervention for women with endometriosis? Why this is important? Pain is one of the most debilitating symptoms of endometriosis. Endometriosis-related pain can be acute or chronic and can adversely affect the woman's quality of life, ability to work, and can affect partners and their families. Pain management programs have been found to be effective in managing chronic pelvic pain and can improve quality of life. However, it is unclear how much of this small evidence base can be generalized to women with endometriosis, for which evidence is lacking. Furthermore, pain management programs have not been compared with other treatments available for endometriosis. Pain management programs promote self-management and are often provided in the community. If found to be effective for endometriosis, pain management programs would provide an additional or alternative treatment options for women experiencing endometriosis-related pain. Groups of particular interest are women for whom hormonal and surgical options have been exhausted, women who would prefer an alternative to pharmacological or surgical approach, and women who may be prioritizing trying to conceive. Laparoscopic treatment of peritoneal endometriosis, excision or ablation. Is laparoscopic treatment, that is excision or ablation, of peritoneal disease in isolation effective for managing endometriosis-related pain? Why this is important? Isolated peritoneal endometriosis can be incidental finding in women who may or may not experience pain or other symptoms. Research is needed to determine whether laparoscopic treatment of isolated peritoneal endometriosis in women with endometriosis-related pain results in a clinical and cost-effective improvement in symptoms. The current literature does not provide a clear answer because the stage of endometriosis is often not sufficiently clearly defined in research studies, and the treatment modalities used are multiple and varied. The resultant amalgamation of various stages of endometriosis and variable treatment modalities leads to a loss of certainty of outcome in specific group of women. Establishing whether treating isolated peritoneal endometriosis is cost-effective is important because this forms a large part of the workload in general gynecology and uses considerable resources. Lifestyle interventions, diet and exercise. Are specialist lifestyle interventions, diet and exercise, effective? Compared with no specialist lifestyle interventions for women with endometriosis. Why this is important? Endometriosis is a long-term condition that can cause acute and chronic pain and fatigue. It has a significant and sometimes severe impact on women's quality of life and activities of daily living, including relationships and sexuality, ability to work, fertility, fitness, and mental health. Supporting self-management is critical to improving quality of life for women with endometriosis. Information and support. What information and support interventions are effective to help women with endometriosis? Endometriosis algorithm. Suspect endometriosis, including in young women age 17 and under with one or more of chronic pelvic pain, period-related pain, dysmenorrhea affecting daily activities and quality of life, deep pain during or after sexual intercourse, period-related or cyclical gastrointestinal symptoms, in particular painful bowel movements, period-related or cyclical urinary symptoms, in particular blood in the urine or pain passing urine, infertility in association with one or more of the above. Assess women's individual information and support needs. Take into account their circumstances, symptoms, priorities, desire for fertility, aspects of daily living, work and study, cultural background, and their physical, psychosexual, and emotional needs. Also discuss keeping a pain and symptom diary. Offer an abdominal and pelvic examination to identify abdominal masses and pelvic signs. Consider an ultrasound scan. Beware that endometriosis can be a long-term condition and can have a significant physical, sexual, psychological, and social impact. Women may have complex needs and may require long-term support. Offer initial management with a short trial, for example 3 months of paracetamol or a non-steroidal anti-inflammatory drug, NSAID, alone or in combination. Hormonal treatment, combined contraceptive pill or progestogen. Refer to NICE guideline on neuropathic pain for treatment with neuromodulators. Second option is, if fertility is a priority, the management of endometriosis-related subfertility should have multidisciplinary team involvement with input from a fertility specialist. This should include recommended diagnostic fertility tests or preoperative tests and other recommended fertility treatments such as assisted reproduction. Also see fertility is a priority on page 2. Consider referral to a gynecology, pediatric and adolescent gynecology or specialist endometriosis service. If a trial of paracetamol or NSAID alone or in combination does not provide adequate pain relief, initial hormonal treatment or endometriosis is not effective, not tolerated, or is contraindicated. Consider referral to a gynecological service for severe, persistent, or recurrent symptoms of endometriosis, for pelvic signs of endometriosis, or if initial management is not effective, not tolerated, or is contraindicated. Second possibility could be refer woman to a specialist endometriosis service if they have suspected or confirmed deep endometriosis involving the bowel, bladder, or ureter. Another possibility could be consider referring young women age 17 and under to a pediatric and adolescent gynecology service or specialist endometriosis service, depending on local service provision. Do not use pelvic MRI or CA-125 to diagnose endometriosis. Consider transvaginal ultrasound. To investigate suspected endometriosis, even if pelvic and/or abdominal examinations are normal, for endometriomas and deep endometriosis involving the bowel, bladder, or ureter. Consider a transabdominal ultrasound scan of the pelvis if a transvaginal scan is not appropriate. Do not exclude the possibility of endometriosis if abdominal and/or pelvic examinations or ultrasound or MRI are normal. Consider referral for assessment and investigation if clinical suspicion remains or symptoms persist. Consider laparoscopy to diagnose endometriosis even if the ultrasound was normal. Discuss surgical management options with women with suspected confirmed endometriosis. What laparoscopy involves and that it may include surgical treatment with prior patient consent. How laparoscopic surgery could affect endometriosis symptoms. The possible benefits and the risks of laparoscopic surgery. The possible need for further surgery, including possible need for further planned surgery for deep endometriosis involving a bowel, bladder, or ureter. During diagnostic laparoscopy, a gynecologist with training and skill in laparoscopic surgery for endometriosis should perform a systematic inspection of the pelvis. If a full systematic laparoscopy is performed and is normal, explain to the woman that she does not have endometriosis and offer alternate management. In this case, there are two scenarios. If fertility is a priority, offer excision or ablation plus adhesiolysis to women with endometriosis not involving bowel, bladder, or ureter. Offer laparoscopic ovarian cystectomy to women with endometriomas. Discuss the benefits and risks of laparoscopic surgery for deep endometriosis involving the bowel, bladder, or ureter. This may include effect on the chance of future pregnancy, the possible impact on ovarian reserve, the effect of complications on fertility, alternatives to surgery, other fertility factors. Do not offer hormonal treatment to women with endometriosis who want to conceive. Consider outpatient follow-up for deep endometriosis involving the bowel, bladder, or ureter, or one or more endometrioma larger than 3 cm. The second option is if fertility is not currently a priority. During diagnostic laparoscopy, consider laparoscopic treatment if perinatal endometriosis is not involving the bowel, bladder, or ureter, uncomplicated ovarian endometriosis. Consider excision rather than ablation to treat endometriosis. For deep endometriosis involving the bowel, bladder, or ureter, consider pelvic MRI before operative laparoscopy, 3-month course of GnRH analog or agonist before surgery. Consider hormonal treatment after laparoscopic excision or ablation. If hysterectomy is indicated, excise all visible endometriotic lesions at the time of hysterectomy. Discuss with the woman what a hysterectomy is, its risks and benefits, related treatment and likely outcome. Finally, treatment should be focused on the cause and concern of the patient, that is, infertility or pain.